I'm Natasha Smith. I'm the ward manager here at the hospice. I've worked for the hospice for 14 plus years. I came here as a nurse from the hospital, from the acute NHS, and I knew I loved palliative care, and I've worked my way up from reducing my hours from full-time and having children to now being a full-time ward manager as a mum of 4. So yeah, that's me. So I use Radar in my role to make sure that I've got full oversight of events, risks, concerns on the ward really. I log on, I check whether there's been any events that have come in the last sort of 24 hours or while I haven't been here, look at what they are. I really want to know the patient that's involved in that. And really my then priority is actually, okay, are the team working today aware of that risk? So it's about communicating that back down, making sure we've dealt with whatever that event might be. So if a patient has fallen, say, lovely, I can see that by the documentation on Radar, but have we translated that into how we're going to care for that patient today? Have we communicated that really well with the staff to make sure that we're all supporting that risk as best as possible? And have we communicated with that patient and their family to make sure that we've done the right thing by them and that they understand what we're aiming for and why we see that risk there? The other thing I do with Radar is I'm able to use it to look at trends and connections. So something that I see is really important in my role is the team log the Radar. They're aware of that. They're aware of managing that risk on a daily basis, but it's my job to look at where we're going in terms of trends and themes as an organisation and a unit. So actually if I'm starting to see that we're having quite a few of a particular situation happening, okay, so what's sitting underneath that? What connections can I make? Is it that I need to think about some learning for everybody? Do I need to target the learning in a right way? And because Radar produces graphs and charts, I can see that really quickly, and it makes it more relatable for the team. They don't want to sit and listen to me do a 3-hour talk on why we've suddenly had an extra fall that month that we didn't have the month before. But actually if I can show them a graph that translates that information really well, they suddenly go, oh gosh, yeah, I can see why you're so concerned about whether or not that risk assessment was completed. It just makes the information a bit more connected for the team. It's made it a bit more efficient because all the information's in one place. So I know that if I want to find out about a policy, no one remembers every policy going, do they, or a document or a form. I can just quickly click on the right button on Radar. I know where it is. If I want to investigate an incident, I know I can upload all the relevant additional parts. So it might be a drug chart that I want to upload. I put that on there, and I know that when I want to come back to that incident, I know where to find it. It just makes it's efficient. It's all in one place, and I can just log on to the bits I need to when I need to. And then there's the wider part of the governance element of my role that I think it supports really well, because I need to be able to understand where my risks lie as a ward. I need to be able to understand where the improvements are. We should always be striving for things to be better as much as we feel we're doing really well, and also to be able to acknowledge the things that are going well. So where things have improved, can we pick that up? How can we communicate that back to the team? If I didn't have all that information in one place, it would likely be in a subfolder here and a subfolder there, and actually the likelihood of me having the time to collate all that together is pretty slim in a role like mine. So it would be very disjointed, and it would mean that my forward planning would be not very robust. It would be a bit, I might focus on this one day and that another day, and I don't think my outcomes would be very good as a result. I don't think we'd improve things very well. Where we were able to log our events and notice the learning that was coming out of them, and then I guess able to look for themes overall by multiple events, we really recognised some areas of communication of those risks wasn't quite where we wanted it to be. And what we were able to do was implement something called a safety huddle for our ward. So every day my team meet at 1 o'clock and they are able to look at all the potential risks that are involved on running that shift. So it might be patients that are at risk of falling, it might be priorities for pressure area care that day. But what we do, because we are St Nicholas Hospice, and we don't want to lose sight of that, is we also incorporate the priorities for the team. So what are your priorities as a nurse? What are your priorities as a healthcare assistant? What are yours as a doctor? And then we talk about, are we going to have some additional conversations with families today? Have families raised something with us that we should all be aware of as a team? Have a patient raised something with us that we should all be aware of? What we hope is that allows a team to pause in their day, take stock of all of that information, and then continue their day in a really efficient and organised way, rather than carrying on their day and lots of different bits of information are being given but not communicated well, and then you get to the end and you realise you should have done something that you could have identified had you had a safety huddle. That only really came about because we were able to see trends and themes of what events were occurring. I think that ability to look at drug charts in that moment has seen a reduction in our medication events because we're prioritising looking and checking, that because we don't have an electronic system for medications. So human error does occur, and it enables that to be picked up really quickly. The safety huddle only came about because of what we were picking up on radar as themes. I didn't have lots of qualifications when I stepped into this ward manager role. I was a nurse that worked 6 nights a month, and they needed a ward manager, and I just thought I'll give it a go. As a result, it means I don't have a big branch of underpinning knowledge about governance or structures that run outside of what we do. So having the use of a radar system that can collate some of that information together for me, or I might know that I need to understand something and I can go to our governance lead and he'll go, oh, well, radar does that for us. You can use radar. Recently, they've shown us the dashboards. They're really helpful to understand the things that matter to me, to be able to pinpoint that to what my priorities are. It allows me to understand things into the right level of context so that I'm not focusing too much on something because it matters to me. If we have some feedback from a patient or a family about their experience, and it's something that I think we need to improve upon, what's the data saying? Does the data support that? And if that's the case, it kind of gives me more credibility if I'm trying to create a project or deliver some education. It just allows a bit more substance rather than just I fancy doing it. You need to have the evidence underneath, and I think that does that. And it means it's not just isolated about that one patient experience. The likelihood is that that's the one patient that vocalised it, but there may be a few others that have had a similar experience that we can't forget. We were really good at logging events and we were really good at investigating them, but what we weren't very good at was communicating that information back to the team. But it needed to be succinct, and it also needed to not feel punitive. It needed to not feel like it was looking at individuals. It was just an overall position of learning. So all of those statements, so when you do a radar, that last section's about lessons learned, all of those statements that we put on there are collated into a quarterly lessons learned from radar newsletter. So they're real snapshots of information, and they don't give you the event or the detail, but they give you the thing we need to focus on moving forward. Therefore, they're quite a positive message. They don't allow us to focus on extra intricacies that could make it more emotive, and they give a really succinct message as well of what you want the team to focus on. That's been really helpful, making sure that we give that information back and close that gap. Otherwise they think, well, I don't know why you asked me to do these event forms, because I never hear anything that happens with them. So actually they're not going to be engaged, are they, if they don't think they learn anything from it themselves? And then we use that lessons from radar to allow us to plan our future learning needs or education needs, because we can see the themes that are coming up from there as well. So that's quite helpful. What I realised quite quickly, because I'd never investigating in incidents is not something I'd done particularly before. It was just kind of given to me as part of my role. Because I didn't come with any preconceived ideas about how that messages were meant to be delivered, I was able to just do what felt natural to me. And what I really recognised was that we were really good at investigating incidents. We were really good at making sure that they were reported well by the team. But what we didn't really do is feedback so well to the team. We created organisational aims and higher level aims, but we didn't bridge that gap for the team. We did, so that all they were told was, right, now we want you to make sure you complete that assessment within so many hours, but we didn't take the time to explain why and what was sitting underneath that. That's been quite important. I think because I've come from working on the ward, I'm able to know what I didn't understand about what I was experiencing and why I sometimes felt my priorities were not necessarily aligned with the managers above me. It's quite a difficult job because nurses just want to care for patients. That's what we want to do. As a nurse, you want to make sure that a patient feels supported. You want to make sure that they have their priorities met. If the choice is filling out that pressure area assessment or that radar or sitting with somebody and helping them have a cup of tea, how am I ever going to argue for them that actually that's really important? So I just need to really use what I have available to me to get that buy-in for my team, but not lose what we're about. St Nicholas Hospice is about patients, it's about families. My relative was here and I really understand that, but what I'm able to understand now in my role is that if I hadn't had the people working above me at that time, making sure that we were doing things the right way, that we were adhering to policies, that we weren't losing sight of where our areas of improvement were, then my grandmother wouldn't have had the experience that she had here. So it does all interrelate. My job is to make sure that people understand that relationship. I think it's really important to hear all those views because each one will come with its different rationale, but they might not necessarily understand the other elements to it as well. So we're really keen to receive feedback from patients and families. I'm quite keen to receive the feedback from people that haven't quite had the experience they hoped for, because that's where we learn the most. We have so much lovely feedback about how wonderful hospice care is here and how the patients are looked after, and that's the bread and butter of the feedback we received, and we're really lucky to have it, and I know why we have it. But every now and then we won't quite get it right, and you have to accept that in healthcare. You're not quite going to get it right for everybody, and that's where we need to learn the most. And one thing I learned about a year ago, I wasn't visual enough at that point in time, and suddenly when I was, a family wanted to give me an awful lot of feedback, so I just took the time to listen, just created a space and just allowed them to tell me what they needed to. I didn't have my set pro forma of what they needed to talk to me about, and I just said, look, I'm just going to make notes and you just tell me everything you want to, and let them lead the way. And I really realised at that point how important it was for somebody who wasn't delivering the care to be accessible for feedback, because it's not so easy to give feedback to people that are delivering the care, because you still feel really, the care they're offering you is really great, but it doesn't mean to say there might not be things you want improving. So what we did was we set up our tea trolley, where we have a lovely trolley, we've got lovely pinnies that we wear, and we have tea and coffee, and we just go around the ward and offer tea and cake to all the patients and to all the families that are there. But what we also do is, because you can't lose sight of the fact that if my team don't feel valued, I will lose them, and they are what are giving the patients what they need. So we make sure that anyone who's working, whoever they are, volunteer, cleaner, doctor, nurse, whatever, if they're there, then they'll get offered tea and cake as well. That kind of all-inclusive approach just means that you really are showing people you value them, and I think when they feel valued, they feel more able to share their experience with you, because they know that you really want to hear it. For a team, they have regular one-to-ones. That's really important, that they have a space to be able to share their own feedback. It's about checking in when you arrive, checking in when you leave, and it's also about being courageous enough to read between the lines. We can all walk into a room and sense when someone's not having a good day, and it's about not ignoring that and addressing that head on, and taking the time to what's going on here, and you'll get a piece of feedback, and it's about being honest about what you can and can't deal with. I can't make that better for you, but what else could I do to help? Particularly when it might be staffing, just like other organisations, we've had staffing concerns, and I can't necessarily make that better in a moment, but Can I protect so you can have a break? Can I make you all a cup of tea right now? It's just about making people feel that they're important, and they are. They're really important. So all our cards that we get, they're all scanned and put onto radar, so they're all in one place. Like it or not, we're governed with CQC behind us. We need to be prepared if they were to come in to be able to evidence and support the things they'll want to know about. So we need to be able to do that efficiently. So where possible, all that information is collated in one place, and our admin team support us to do that. So the information is shared with the team, but it's put onto radar so it's in one place. All the policies are on radar anyway, so that's where they're going to log their incidents. So if they want to check the actions to be taken after a fall, they can look at the falls policy that way in the same place, so they're not jumping from here to there or looking for a file on the shelf or something like that. Have historically, with some of our incidents, put that footnote in to remind the team, have you considered the policy when you're filling out this form, to make sure that you're not missing anything as well. Any changes to policies are updated, and that's communicated to the organisation widely, so it might be like a group email just to let you know there's been an update or something like that, so people know where to go. But I think having them all in one place is actually just what makes them so accessible. Like everywhere, we use IT and computers, so that the access to that is for every individual on every computer, so you don't have to be in the right place to be able to access them as well. We have made some tweaks along the way, and actually less so to do with the policies and the logging of incidents, but more so to do with the auditing process. Those three things should be interrelated really well, and sometimes they weren't. What we were auditing against was not necessarily what we were asking the team to comment on in event, and different element of that might have been within the policy. So actually you're asking three slightly different things, and that's inconsistent and doesn't help anyone, because the data you'll get won't be helpful. So we have made tweaks along the way, and I think that's been really helpful and really important. What we recognised some time ago was that we were logging events. I had quite a good understanding of those events, but I was concerned that the roles that sit above mine, so head of nursing, director of care, didn't have necessarily the same detailed information that I had, and obviously your workload can get quite big, and it's making sure that we're sharing that knowledge of each other's workload and the risks that are sitting on the ward, really. Partly because we're all managers on call as well, so it's really important for the out of hours side of our role that we have an understanding of what the risks are sitting there, because that's what we'll get calls about. So now every Monday we have something called a quality huddle, where we look at all of those risks, but we also look at all of our events that we've logged on radar. And more recently, what we've also done is taken the time to think, okay, well, we're really good at logging them, but how are we at making sure we're keeping on track with that level of work in amongst all of our day-to-day reactional work? So now what we do is also look at the progress of those radars. So where are they sitting? Have they got action plans that are still waiting to be actioned? Who do the responsibility lie with, so that we are clear about everybody's workload and transparent about it? It's almost a little bit like the safety huddle the team do on a daily basis. It's for us as managers on a weekly basis. And again, I think for me, that's about making sure these connections are going on from bottom to top and top to bottom. It's uncomparable. The NHS is an absolutely amazing organisation to work for. What they're delivering under the conditions that they're having to work within is really, really special. But what you can't do is the extra things that I'm able to do here. And I think that can be really difficult, because when somebody decides they want to be a nurse, they do it because they care about people and they want them to have a good experience. So when I came to the St Nicholas Hospice, I was able to work a shift, have a break, go to the toilet, end my shift on time and walk away. I didn't have any worries, I didn't have any concerns, and then I was able to come back again, refreshed, ready for the next shift. And that was the first time in my career that I've been able to do that. And it was because our staff-patient ratio allows us to do that. It was because we're all focusing on the same goals at the end of the process. It's because we're a small organisation, so we're able to dictate how we function ourselves. We don't have those same constraints as the NHS. And I think to be able to be the nurse that you train to be is very, very unusual. And really precious, hence why I've stayed here so long. I just couldn't do that anywhere else, I don't think, in any other role. I did adult nursing training, and I worked for 2 years in acute medical ward, which is where I met most of the patients that were palliative patients that were dying, and I really started to understand that that was where my love was. I loved just taking that time to support people at such an important time, and their families. But I knew that the way I could do that in a big medical ward with lots of other priorities was difficult. And when a job came up here, they didn't come up very often at a hospice, so I kind of jumped at it really, and I've never looked back. And you know, all jobs come with their difficult days, don't they, where you think, oh, perhaps I should go and look for something else. But every time I've thought to do that, I've never been able to find a role that I think, oh, it gives me enough of the things I get here that would draw me away, really. There's nothing quite like supporting patients and families, and working in an environment that feels safe as well as a nurse is really, really important. Yeah, so I'd worked here for quite a long time. I came here, worked full time. I've then had 4 children, stepped my hours right down to 6 shifts a month. And then my grandmother became quite very unwell very suddenly in an acute hospital, and we knew she was dying quite quickly. And I instantly knew I needed to bring her to the hospice. So we had a bed available. She was referred just like everybody else and was given a bed here. Immediately, I wasn't a nurse on this ward anymore. I was a family member. I was a granddaughter, and I sat in that room with my grandmother for 6 days with my other family, and was just a family member. I didn't engage in any other element other than holding her hand, helping her have a drink. And that really taught me how important the other things were that were here, that were not written down, the things that are not sold about St Nicholas Hospice. You know, when you're sat in that room and you've been awake all night with your relative and somebody comes in and says, would you like a cup of tea or a piece of toast? Like, we used to sit there and go, oh, do you think we'll get tea and toast this morning? Like, they were the things that kept us going. You know, the cleaner coming in and smiling at you when they change the bin and having a chat with you. Absolutely, the medicines are really important. Absolutely, all the complex care needs are really, really important. But we're all humans, and human interaction is what makes you feel like it's okay. It's okay to have a little cry because this is really rubbish, but it's actually not wrong to laugh either. It's okay to laugh in a hospice. It's okay to need to go, oh my God, I need to get away from my own family and walk around the garden for a minute. I didn't understand how important those things were until I became a relative. And during COVID, a lot of those things started to disappear because of the way we had to function during COVID. And then the ward manager post became vacant. And I was concerned that if somebody came in without those additional elements of knowledge, they may lose what is St Nicholas Hospice. St Nicholas Hospice is that garden, is that ability to sit in a room and look at the lights or hear the birds or see the squirrels coming in when they shouldn't be. That's what makes us, and our ability to work together as a team, really, and hear everyone's viewpoint. Who else had that knowledge if you came from external to the organisation? And I thought, you know what, I don't have a clue what I'm doing, but I'll put myself out there and see. And I didn't for a million years think they'd employ me in the role, but they did. And I've just used my instinct to deliver what I think is right and learned loads by my mistakes, but ultimately try to focus on remembering my own experience and using that to motivate me to keep doing the right thing where possible, but being prepared to hear other people's perspective. It's very unique. We are a small organisation and things are done slightly differently, as with all small organisations, but because it's small and I work in a hospice that's a voluntary sector, it means I get to experience things that I wouldn't have experienced in the NHS. I have time with fundraising, I meet the finance department, I work with the catering team, I work with the marketing team. I meet families that are raising money for us. It's extra elements of my role. It makes me really understand the importance of doing things right, because somebody's really taken the time to go and run 6 miles for me to be able to do that. You can't take that for granted. You really have to utilise that money that you're given as best as possible. I think anybody who comes to work in a hospice has usually got a bit of a story behind it. And everybody will say, oh, I couldn't do that job, but we're doing it because of our own self-drive as well. We're not angels. We get a lot out of helping people, and you can't deny that. We're all really, really emotionally motivated as a group of people. We really feel everything we do. We feel each other's experience as colleagues. And because of that, we take the time to support one another when it's difficult and acknowledge that. And I think it's that kind of camaraderie that I think you don't get everywhere. And we laugh and we have a sense of humour that I think is quite unique to us. And that really is so valuable for keeping your resilience. I don't think if it wasn't for the way we functioned as a team that's unique to us, I don't know that we could deliver what we deliver. So we're quite prepared to accept that someone might be having a difficult time in life, and we all pull together to support them. We might all accept that today is a good day for a laugh and have fun with our patients. That's just as important. We are professionals. We don't lose our professionalism along the way, but we are humans, and that's what I think drives you to this organisation. You're treated like a person. You're treated like a person that's an individual and that you matter, not that you're a number, you're nurse number 5 that works full-time equivalent of whatever. That's not who we are. I'm Natasha, I know what I bring, and I know what each of my team bring because they're them, and if they weren't there, I would lose that. I couldn't get that from employing another nurse, and that's what I try to let them understand. Part of the way we deliver care, we think about what's important to the patient. So they might come in with pain, or they might come in because they've got a lot of nausea and vomiting, or they might come in for their end-of-life care, but it's what matters to them during that period of time. Is it that they really want to spend some more time with their dog, or is it that they've got a wedding for their child that they want to attend, or is it that their own child has a school play that they want to be able to go to? And it's about thinking about those goals and how we can support them to be met, and how we can support people to feel that they are a person. They're not just patient in bed too. So if you love being outside, let's push your bed outside the doors and enjoy the sunshine. Have an afternoon tea with your family in the garden. If you're a couple and you can't remember the last time you had a meal together as a couple, just being a couple because you've been so focused on your health, just go into our family room and we'll put some decorations up and we'll put a candle there and you can have a lovely meal together. Bring your dog in, put it on the bed. We have the ability to, we can't make your journey go away, but we can give you some memories along the way, and we can give your family some memories that won't just be about the real suffering that you endured at that time. It will be about some really precious moments that you were really pleased you had the opportunity to have. Frequent comment that I think I ever have, and actually my own mum said it when we came in, is I didn't really know much about what hospices were. And my mum even said to me about my grandmother, she said, I didn't really know why you were pushing for her to come here so much. I couldn't really see what we'd get out of it. But she said the minute we walked in, I felt the weight lifted off my shoulders. And the amount of families that say that, I don't know what it is about the environment that allows you to feel that way, but it's quite a calm place to be.